Everyone. I am Dr. David Kean. I'm an assistant professor in the Master's in Athletic Training program. And I would like to introduce one of our second year students, Rian Stevens. She's going to give a very interesting talk on lateral tenodesis and rotational instability after ACL injuries. All yours, Rian.
Thanks. So as Dave said, I'm Ryan, and today I'm going to be talking about the lateral extra-articular tenodesis and decreasing rotational instability in ACL deficient knees or anterior cruciate ligament tears. Alrighty, so a little introduction. So the lateral extra-articular tenodesis, or the LET, is a surgical procedure that's used to improve rotational instability in an ACL deficient knee. This surgical technique was discovered by Dr. Lemaire in 1967. This surgical procedure gives the basis of future extra-articular procedures, and it's described as taking a 1.5 by 18 centimeter strip of the IT band. And y'all can kind of see where the IT band is here. This is pretty much a modified version of the LET, or the Lemaire procedure. So they're going to take that 1.5 by 18 centimeter strip, and they're going to loop it underneath the lateral collateral ligament. So the ligament on the outside of your leg, they're going to loop it under that, and they're going to take it through an osseous tunnel, or just a bone tunnel in the femur, and then they're going to loop it back under the LCL, and then they're going to attach it at the end, or the insertion point of the iliotibial band. So that is the basis procedure of the lateral extra-articular tenodesis, but there are some different modifications that you can make, and we'll talk about one of those later in the presentation. But the purpose of this surgical procedure is to decrease rotational instability in ACL deficient knees and to decrease varus and valgus laxity, as well as internal and external rotation while the knee is in full flexion.
I'm just going to interrupt. Is it a synthetic strip or part of your own body?
It's your own body. Yes, ma'am. So getting into the anatomy of the ACL, we've talked about ACLs a lot today. And so just a little overview again. It is a dense connective tissue that's going to connect your tibia to your femur, and it's going to prevent anterior tibial translation relative to the femur, as well as rotational loads. So the LET is a great surgical procedure to understand, but there is some basic inclusion criteria for who fits this mold or not. So the first one is having a revision ACL reconstruction. So basically what this is you tear your ACL once, you return back to your sport, and then you tear your ACL again. So this would technically be your revision ACL reconstruction. The second one would be high rotational instability, and this is typically going to be tested using special tests, similar to what Cody talked about earlier this morning, using the pivot shift test, and we'll go over that later. The third one being generalized ligament dyslaxity, or genu recurvatum. The picture right here on the right stance is a normal stance, and then genu recurvatum is basically just having hyperextended knees. And then finally, being less than 25 years old and wanting to return to contact sports. So these are our special tests. So we have the anterior drawer first. That one's going to be testing anterior tibial translation. So as you can see, the clinician is holding the proximal end of the tibia and the fibula, and he's drawing it forward, testing the anterior tibial translation. The Lachman's is similar to the anterior drawer. It's just different hand placement and at a different angle for the knee. So his right hand is grabbing the proximal aspect of the tibia, and his left hand is stabilizing the femur, and he's going to be drawing that right hand forward, testing the integrity of the ACL again. And then the final, special test in the knee is the pivot shift test. So this one has a couple more moving parts. So you're going to be internally rotating the tibia, but you're also going to be applying a valgus or an interior force on the knee while also flexing the knee. So it's going to look like you're doing this almost to the knee for a pivot shift. All right, so getting into my focus clinical question, I used a PICO format, and my patient population is athletic individuals with ACL deficient knees. My intervention is the LET. My comparison is an isolated ACL reconstruction, meaning that they are only fixing the ACL, nothing else. And then my outcome is decreased rotational instability post-operation. So my search strategy, the databases that I used were the JSU Library, PubMed, Google Scholar, and Sport Discus. My search terms were the lateral extra-articular tenodesis, ACL tears, rotational instability, and rotational instability post-operation. So my inclusion criteria, I wanted articles published after 2010, written in the English language, and ones that talked about ACL reconstruction with the addition of the LET. Exclusion criteria, I did not want any studies performed on cadavers or studies performed on patients that are older than 60. Here's my evidence quality assessment. I use the Pedro scale and the consort checklist, as well as the levels of evidence. The results of my search showed 5,300 articles throughout all of the databases that I used. 9 of them are used throughout this presentation. 5 give general understanding of the LET, and then the other 4 are used testing the LET and the rotational instability. So getting into our research, this first study compared a single bundle ACL reconstruction with and without the use of the LET. So the primary outcome of this study was a graft failure in terms of rotational laxity, which is going to be tested using a pivot shift, or clinical failure of the graft, meaning that it's torn again. So results of the study showed that 40% of the isolated ACL reconstruction group, so they just had their ACL reconstructed, nothing else, they didn't have anything added, had a 40% failure rate, whereas the additional LET group had a 25% failure rate, so that is significantly lower. My second study hypothesized that adding the LET to revisions of ACL reconstructions would reduce the risk of ACL failure or ACL reconstruction failure and enhance patient-related outcomes. So this study used, obviously, patient-related outcomes using a clinical examination, a symptom check, and a functional outcomes assessment. So a clinical examination is typically like when you go to the doctor and they're looking in your ears and different things like that, but more for the ACL itself. So the results of the clinical examination showed that the isolated ACL reconstruction group had a an increased positive pivot shift test, and that's the one that tests pretty much rotational instability for the knee, whereas the LET group had a decreased positive pivot shift test. And then as far as patient-related outcomes, the LET group showed positive outcomes across the board except for their pain scale. The third study assessed whether adding the modified Lemaire to an ACL reconstruction could significantly improve knee stability, clinical outcomes, and failure rates in pediatric patients. So knee stability was assessed using the KT1000 and a pivot shift that was quantified by the kinematic rapid assessment, which is also known as the KIRA. These measurements were taken 5 times bilaterally, which just means both sides, at the preoperative appointment and at the final follow-up. So the results of this study showed that the LET had superior results at the final follow-up when compared to the isolated ACL group, so they had better results then. The fourth and final study evaluated the role of Cocker-Arnold's extra-articular procedure in reducing the incidence of residual post-operative rotational knee laxity. So, they used the Lockmans and the pivot shift test preoperatively and at their follow-up appointments to assess rotational laxity. The Lockmans showed more positives than the pivot shift, but 59% of the additional LET group showed a negative test, meaning that their ACL was intact and they didn't have any rotational laxity. So 59% compared to the isolated ACL group that had 71% negative tests. And then as far as the pivot shift, which is really getting into the rotational instability, 43% of the isolated ACL group had a negative test compared to the higher percentage of the additional LET group that had an 81% negative test. That's significantly better. So the clinical bottom line, adding the LET to an ACL reconstruction can assist in decreasing rotational instability and graft failure in ACL reconstruction patients. Some implications for this, as I said, adding this procedure to an isolated ACL reconstruction can decrease the amount of rotational instability and graft failure post-operation. As an athletic training student, hopefully going to be an athletic trainer, the inclusion criteria is really good for us to have because not everybody needs this, So understanding who might be the best candidate for this is a really good thing to have in our back pocket as athletic trainers or just clinicians in general. And then finally, I think more research should be done on the collegiate population, just because they do perform at a higher caliber, say, than the pediatric population or somebody who is above 25, unless they're in the professional population. But I do think that collegiate athletes should be studied a little bit more for this. Here are my references. I just want to say thank you to the JSU Student Symposium, my professors, my colleagues, classmates, colleagues too, and then my family and my husband. So, thank you. Any questions? Yes, ma'am.
I can't remember what slide it was, but you talked about having an increase or a decrease relative to their starting point and then post-surgery, a decrease in the way they could move their knee. I wasn't really sure if you could explain a little bit more what you mean by increase or decrease.
So, I think you're talking about
Yes.
this one.
Mhm.
So it's really just the clinical examination is going to basically they just do each group and they'll test it. So it's not necessarily relative to the beginning or the end. It's more of they're going to test in an objective way to just test everybody across the board. So in this case, the group that had the isolated ACL reconstruction tested more positively, or not positively, they had more positive tests for the pivot shift as compared to the LET group that had less positive pivot shifts.
Positive for a tear.
Yes, ma'am.
Were there p-values in the articles that you did?
I am not entirely sure, but they're referenced at the end if you would like to check. Any more questions? No?
If not, another
Cool.
round of applause.